Hey, Justin Jolene here. Check out this case study of a 29-year-old female runner with mid-portion Achilles tendinopathy. She reported pain after running and especially at faster paces. So let's check out her running gait analysis. Let's look at how we can fix these issues, how we can rehab her and return her to running. Now you can see on her running gait analysis, she has a forefoot strike pattern at initial contact. Elements of overstriding, limited terminal hip extension, excessive vertical oscillation, and a cadence of 156 steps per minute. Now let's break this down on how this gait could be affecting her mid-portion Achilles tendinopathy. Now the biggest factor we could see is that forefoot strike at initial contact. You can see that at times her heel isn't even contacting the ground during stride, which is going to put a large tensile force on her Achilles tendon. It's going to lead to high loads and potentially inflammation for her pain. Now you can also see here she has a lot of vertical oscillation as well. That's going to require a lot of plantar flexion. All that plantar flexion muscle strength and all that load on the Achilles is going to reproduce symptoms. And then you can also see she has a low cadence, relatively long step lengths, which are going to prolong mid stance and increase Achilles tendinopathy load, but she does have minimal terminal hip extension. Now, on the physical examination, the patient showed good strength in hip extensors, hip abductors, knee extensors, knee flexors as well, which is great. We know that the hip stabilizers and knee stabilizers can influence Achilles tendinopathy and can increase load on Achilles tendinopathy when weak, so we don't have to worry about them as much when we're looking at a return to run plan. However, we really should perform a single leg heel raise test. So for her, we saw 12 reps on the affected side and 24 reps on the non-affected side. Now it's important here for clinicians to know how to use this single leg heel raise test. This is really, really important because we need an evidence-based way to be able to measure plantar flexion function and strength, and we need to be able to know how much the Achilles can tolerate load. This single leg heel raise is a great way to do that. So how do we go about doing the single leg heel raise test? Well, first off, speed is really important. 60 beats per minute. That's going to be really important to make sure patients follow 60 beats per minute. Use a metronome to make sure you're consistent. And you want to make sure they're getting full plantar flexion each time. You want to make sure their heel comes up to the same height. Obviously, we want to make sure they're not using compensation strategies. Nothing at the knee, nothing at the trunk, nothing at the hip or ankle as well. We don't want pronation, we don't want knee flexion, we don't want hip or trunk flexion as well. And really, barefoot's going to provide the best results. So keep the surface flat, keep them barefoot. That's going to be the best way to go. Some people will have folks do it on a step, but that will actually compromise results. We want to make sure that we are as consistent as possible with this process. Because what we see in the research is that we can actually see 12 less reps on average with standardized heel raises, which means we're getting a better indication, a better measurement of Achilles load tolerance and plantar flexion strength. So we want to make sure we're not incorporating that stretch shortening cycle. Now, let's take a look at how we get this patient better. So what was our approach for rehab? Well, we want to follow the phases of progressive tendon loading, which is going to be tendon loading management and isometrics in the first phase, isotonics in a second phase, heavy, slow resistance training in a third phase, and then finally plyometrics, return to run, all those things. So since Achilles tendinopathy primarily involves tolerance to heel raises, we can kind of condense this down into our three phases here. And we can see that these are going to be really important when it comes to recovering from Achilles tendinopathy. So we can see step 1 is our early rehab, step 2 is our middle to late rehab, and then step 3 is really our late rehab going into our return to run phase. So here is where we start talking about how we're going to recover patients from Achilles tendinopathy. So during these phases, you can see that early on, we're going to do isometrics, some isotonics as well, with our goals going to be single leg heel raises at 3 sets of 15 rep max at the end of this early phase. The middle phase is going to be heavy, slow resistance training, and that's going to be a goal of 3 sets of 6 rep max with weight and we're going to be careful. We're not giving them too much pain. We're not causing too many symptoms. And then lastly, in our third step or our later phase, we're then going to be integrating plyometrics. We're going to be doing a return to run. We're also going to be introducing running drills in that phase as well. So we want to be really consistent with these phases, and we don't want to skip steps. So for this patient, one of the ways we're going to be able to monitor her progress is to be able to take a look at her pain levels. We want to make sure her pain level stays between 0 to 3 out of 10, both during exercise and following 24 hours after exercise. Now, the way to monitor this is single leg heel raises is a really good way to do it, but there's various load tests that you can do, and you can monitor just if she's saying she's getting pain or having problems maybe walking around. Those are all good indicators. But it's really important that you have an in-depth conversation with patients regarding how much they're doing and how to manage their load. For this patient, we talked about reducing her running to 2 miles. That was enough to bring down her pain level, and we had her run every 2 days at 50% of her race pace. Now, she was also advised to limit walking up and down hills, avoid minimal shoes, and avoid jumping exercises in the gym as well. So what are the specific exercises you should use to help patients progress along this progressive tendon loading exercise progressions? Well, there's some really interesting research out there of exactly how to do it. And it's going to be into 4 phases of Achilles tendon progressive tendon loading exercises. Now, this is from Baxter et al., and this is a really, really good article and a really good study to follow. There's a couple different studies that are integrated here, but the important part is to incrementally add more load to the tendon and gradually increase its tolerance to exercise. Since this patient doesn't have uncontrollable pain with ADLs, and we can keep her doing some running, we did skip that isometric phase. However, we went directly to the isotonic phase, and therefore we're going to be starting in our tier 2 exercises of the progressive tendon loading Achilles tendinopathy exercises. So what we started on was some lunges at 2 sets of 10, step downs at the same reps and sets as well, single leg heel raises, keeping reps and sets the same, and then we progressed her towards 3 sets of 15 rep max with weight at a slow pace. Now, that's a large area to cover. There was a lot of incremental changes that we gave her, a little more weight, a little more reps. So we want to be careful here, and I don't want to breeze through this process, but the important part here is that you're giving some training, some strengthening, and then you're going to add more weight early on. We want to be careful. We don't want to add too much load. We don't want to add too many exercises, but we do want to be careful. We want to add some load, put it under tension, because that's what's going to progress them into getting stronger and tolerating more load. So then as we got to our middle rehab phase, we were then being able to progress her down to 3 sets of 6 repetitions max with weight. So higher load, higher intensity. This is our step 2. This is going to be middle rehab. This is going to be heavy, slow resistance training. And because we laid that foundation of strength, we could increase her exercise speed and start to add exercises in that were going to transition us into our step 3, which is going to be that plyometric phase. So we started to add things like rebounding double leg heel raises at 2 sets of 10 and double leg jumps at 3 sets of 7. You can see those are relatively lower on our overall load index here, our body weight load. And so we can give those a little bit earlier on. And there's a quick note here that there's a variability when it comes to patients doing plyometrics or starting to transition to plyometrics. We want to be careful that patients aren't having too much pain here. Now, she had a positive response, and we added tier 3 exercises of single leg forward jumps, single leg counter movement jumps, and double leg drop jumps at 3 sets of 7 each. Now, we added more sets and reps, and when at this point we started to break up the patient's exercise sessions into high, low, medium tendon loading sessions. So for example, for a week of exercise, we would give her plyometrics on day 1, followed by low intensity isotonic exercises, so lower value kind of our phase tier 2 exercises, maybe without weight, depending on what she needed. And then we'd give her a day 3 of heavy, slow resistance training. So that's our weight, our 3 sets of 6 repetition max exercises, single leg heel raises with weight. So she'd have a strength training day. Then we'd give her a day of rest and then have her go through the cycle again. Now, at this phase, we would also start to integrate running, increasing running mileage. We'd also be increasing running frequency and speed as well. Now, there's a whole separate conversation on that, but one of the things we did integrate here was A skips and B skips as well into our program to introduce more running load. Now, finally, we integrated tier 4 exercises of single leg hops at 3 sets of 30 seconds, drop jumps of 2 sets of 10, and forward single leg hops at 2 sets of 10 as well. As you can see, as we start to decrease the ground contact time, we are then requiring more load, more strength to be produced from that tendon. So there's more force, more load on that tendon. That's going to potentially add more strain or add more symptoms. But if we're progressively loading it, we know we can do that with confidence. Now, the other note here is there is some variability with some people with how they do plyometrics. Making sure you have the biomechanics correct is really important. And that's why leaving ground contact time longer as you start plyometrics is really important. Make sure you have the biomechanics at the ankle, at the knee, at the hip first. Make sure you have squat mechanics, the impact loading. Make sure that you can do all that, because once you start to shorten the ground contact time, well, you're starting to engage the stretch shortening cycle. You're starting to engage that plyometric. You're starting to put more load through the Achilles, but you also have more chance that you're going to suffer with form. So making sure you can increase the ground to contact time earlier on is going to help to make sure you're doing biomechanics correctly. Now, the only elephant in the room we did not address for this patient was that they did have some running gait changes that were affecting her Achilles tendinopathy. So we got her better. We got her through our 4 phases of Achilles tendinopathy loading. What do we do here? Well, we're finally going to change her cadence, change her gait a little bit. However, we want to be with a soft touch here. We don't want to do too much because we want to kind of give her a little bit to see how it reacts. So we gave her 5% increase in cadence. We used music to increase the cadence and to give her something to listen to so she could follow it. So it wasn't just a metronome to follow with. Research is going to show music works better than metronomes. And then we wanted to limit that vertical oscillation. So we asked her to actually run a little heavier to encourage more of a heel strike. That was our progression with this patient. She did really well. She was back to running happily, and she was discharged totally out of our care and totally on her way running miles.